Good evening, everybody. I would like to invite all of you to today's webinar, the topic being Allergic Rhinitis. At the outset, I would like to thank the Chest Council of India and the CIPLA Respiratory Division for the coordination and conduction of this webinar. We have the blessings and guidance of Dr. N.H. Krishna Sir, who is the CCI founder and National President, and Dr. Narayana Pradeepa, who is the CCI National General Secretary. Today's topic will be divided into two sections. The first section will be anti-leukotrienes as to be used as an adjuvant to the intranasal corticosteroids. This topic will be taken by Dr. Agam Vora. Dr. Agam Vora is a senior consultant pulmonologist with 20 years of experience who is presently practicing at and as the medical director of the Advanced Medical Specialty Hospital at Vile Parle, Mumbai. Sir is the assistant editor for the Journal of Association of Physicians of India, editorial board member of the Chest India, general secretary for the Academy of Advanced Medical Education. He is the immediate past president of the Geriatric Society of India and also the trustee of the Malad Medical Association. The second part of the topic it will be the difference between using an antihistamine alone and combining it with anti-leukotrienes in the management of allergic rhinitis. This topic will be taken by Dr. Giriraj Bomma, the dashing young pulmonologist. He is an MD in pulmonary medicine and has also attained his fellowship of the American College of Chest Physicians. He is HOD of the Department of Pulmonary Medicine of Mahadevappa Rampure Medical College at Gulbarga. I would like to welcome everybody to this talk, and I will be handing over to the speakers. Thank you.
Good evening, everybody. Thank you, Dr. Tony Baby, for that nice words of introduction. And I'm so happy that today I'm talking on my favorite platform, and that is Chest Council of India's platform. Today's day is very historic, as you have realized now that at CCI we've had 3 web conferences in a day. We started with management of hypersensitivity pneumonitis, then we went on to the management of sepsis, and now we are discussing allergic rhinitis. Today's program is anyway very special because allergy is my very close subject, and the topic that is given to me is leukotriene receptor antagonist. Montelukast is another very favorite drug. I consider myself part of Montelukast because Montelukast, I was part of the launch when it came in 2002-2003. I was part of the first Montelukast and antihistaminic combination because I got a file from Director General of Health Services offices. That time I was heading Department of Respiratory Medicine at Cooper Hospital. And the rationality of this combination, is it goes to 8 or 9 doctors for the reviews, and I was one of it. And as I've seen this leukotrienes receptor antagonist evolution and our understanding about it for almost 1.5, actually probably around 18 years now. And I'm really grateful to the organizers for giving me this topic, which is very close to my heart. I'm again very happy that Dr. Giriraj Bomma is going to be there talking after me and is going to be talking about antihistaminic, another very interesting topic, and there's a lot of confusion that comes to a treating physician's mind about which drug to use first, and we are going to give you the rationality of it. As I said, before we begin, it is the time we fold our hands for 2 seconds for this unprecedented times. Coronavirus has really threatened mankind. 100 nanomicrons virus is fighting with supposed to be the most evolved species on Earth. 50 lakhs cases globally, with 3.5 lakhs deaths globally. More than 1 lakh confirmed cases in India, about 4,000 lives we've already lost in India. In my Maharashtra, if I talk 50,000 cases with about 2,000 deaths in Maharashtra. I pray to God that He gives us strength to fight this virus, to fight this pandemic effectively. And I salute all those who have joined hands and who are offering their services in this tough times to fight this particular disease. My special thanks to my teacher, Professor Director Dr. K.C. Mohanty, whose death anniversary is nearing. On 1st June, we lost him and he'll be completing, this is his 3rd death anniversary. N.H. Krishna and my CCI family, I am so much attached to this Chest Council family. my co-speaker, all of you, my patients who taught me respiratory medicine for decades together, and my daughter Ashka. Today evening was her time. In fact, we were planning to play Ludo. No, we were planning to play that Monopoly game, and I took away her time. So I'm sorry, Ashka, but then we would make up. The agenda that I have in mind for next 15-20 minutes to talk about allergic rhinitis, our understanding today, its relevance to we chest physicians. We manage primarily asthma. Implication of this association between allergic rhinitis and asthma, the pharmacotherapy, leukotriene receptor antagonist, its role, and some take-home message. To begin with, I present 3 cases to you. Imagine a 15-year-old boy, Naishad, has got mild intermittent asthma with allergic rhinitis, is well controlled with intranasal steroids. He took part in school running race, did practice today, had little cough, little shortness of breath, probably something called as exercise-induced asthma, or if I may say exercise-worsened asthma, and he has to participate tomorrow. What advice would you give him? Look at Mona, 23-year-old girl with allergic rhinitis and mild asthma, disease well controlled with aerosols, intermittent sneezing and nasal blockage, well controlled with intranasal steroids. Otherwise, your choice of treatment, the first add-on that you will think now. And a 4-year-old baby gets frequent cough and cold, requires 3 to 4 visits to a doctor for the same. Response to oral bronchodilators with steroids, unwilling to take aerosol therapy and your option of treatment. We would probably derive those answers as we run through these slides. And allergic rhinitis, the way we understand today, is clinically defined as symptomatic disorder of nose induced after allergen exposure, which is IgE-mediated inflammation of nasal membrane. Then it presents with rhinorrhea, nasal obstruction, nasal itching, and sneezing. Direct medical cost, high, even higher in association with asthma. Loss of productivity, absenteeism, poor performance at work, and poor concentration at school. And we've realized it for more than 25 years. Over the last 20 years, we've got enough publications which says that allergic rhinitis and sinusitis or upper respiratory involvement in asthma plays a crucial role in more severe asthma symptoms and more exacerbations. The link between upper and lower airways is strongly supported by epidemiological data, pathophysiological mechanism, clinical evidence, and it has a definite therapeutic implications. I looked at this particular slide some 20 years ago when I came across this paper which speaks about United Airway, the allergy march. It says that probably earlier age you have food allergy, then eczema, then comes the allergic rhinitis, and then the asthma probably at the gap of 1 year. By 2 and 3 years, people start getting features suggestive of asthma. Look at various studies which probably I've just tried to put it in one slide. The epidemiological link talking about rhinitis and asthma going hand to hand. Allergic rhinitis and asthma will have similar prevalence pattern across the globe. I'm sure everybody here has witnessed that all patients of asthma will have some sort of allergic rhinitis, and all patients of allergic rhinitis will have some amount of asthma there. It is thought to be because of postnasal drainage of all this inflammatory material from upper to lower respiratory tract and activation of nasopharyngeal bronchial reflexes. There are similar pattern with asthma and allergic rhinitis, that it has a history of atopy. There is higher incidence in children. There is an immediate phase and a late phase initiation by binding of allergen. That means there is exposure to those allergen, infiltration by inflammatory mediators, and there is role of various anti-inflammatory mediators. Pathophysiology is shared. Again, we have enough number of papers which talks about the same. There may be genetic, environmental correlation. There is hygiene hypothesis. There is a thesis between this early and phase, late phase reactions happening both in allergic rhinitis and in asthma. There is a definite interaction between upper and lower respiratory tract. You look at the electron microscopy structure and you see that there is a lot of similarity. There is pseudosatisfied ciliated epithelium, both mucosal gland where blood vessels, connective tissue, inflammatory cells are there present in both these linings. The difference between nose has got extensive vascularization, whereas bronchi, the airway, has got smooth muscle. But otherwise, majority of the features are the same. And you look at the pathogenesis. In presence of those environment factor and genetically susceptible host, there is atopic sensitization, and on subsequent exposure, you have mucosal inflammation, and there are structural changes which leads to 2 different phenotypes. I believe this allergy disease, there are 2 different phenotypes. There is not isolated asthma, there is not isolated allergic rhinitis, it is part of the same spectrum. You may have a phenotype where there is predominant allergic rhinitis, you have a phenotype when there is predominant asthma, but both these patients will have some sort of the other system involvement. And in summary, the mucosal inflammation is present in the entire airway of patient with allergic rhinitis and asthma. upper airway inflammation is associated with bronchial hyperresponsiveness. If you do adequate test, you will realize there is associated asthma, and lower airway remodeling is present in asthmatics also, but also in allergic rhinitis patients. Look at therapeutic implications. If you treat patients with antihistaminic, there is improvement in PFR. Intranasal steroid improves the asthma outcome, and treating rhinitis helps in asthma management as well. So this is extremely important for our chest physicians to understand that if your patient is not under well control with your asthma, you suspect that this particular type of therapy should bring about improvement in this asthmatic, but patient is not doing well, probably you are missing associated allergic rhinitis. And look at the pharmacokinetic, look at the effect of drugs. You have so many drugs, all these drugs have got effect on the both the organs, that means your nose and the lungs, beta agonist, etc., etc., except antihistaminic. Antihistaminic does not have major role when it comes to asthma. It has got hardly any effect, but rest of the all drugs will have effect on nose as well as airways. And this is the area classification of allergic rhinitis came probably 10 years ago, and then we know that now we look at allergic rhinitis as intermittent symptoms or persistent symptoms depending on frequency. If it is less than 4 days a week or less than 4 weeks, probably you're talking about intermittent. If it is more than 4 days a week and more than 4 weeks, you're talking about persistent symptoms, and then it is divided into mild or moderate to severe. And probably for a number of years, we looked at nose separately and lungs separately, and the coexisting and its impact on correct combined simultaneous treatment was lacking. As asthma was thought to be only lower airway disease, only pulmonologists would treat it. It had pulmonary indications. Brands also, the companies with probably asthma would come to chest physicians, and it became a by and large a prescription product. When it came to rhinitis, people thought it is only upper respiratory part specialists with self-care, or maybe ENT specialists, only nasal implications. Only rhinitis products and rhinitis brands went to ENTs, and probably they never came to us. And then most of these products were OTC brand. But then over the last 2 decades, we realized that there is an issue. There are probably need for common anti-inflammatory drug which could look at inflammation overall rather than managing 2 different end organs. And intranasal corticosteroid are the most effective medicine class in controlling all symptoms of allergic rhinitis. It provides significant relief of symptoms in intermittent or in persistent allergic rhinitis. The overall clinical response does not appear to vary significantly between different intranasal corticosteroids. In the sense, the binding affinities, the lipid solubilities, potency, etc., may not really matter. So far as you're using intranasal corticosteroids, it will have by and large the similar effect. When given in the recommended dosages, it hardly has any side effects. As I probably, the only thing is steroid will take some time. The maximum effect are seen after 2 weeks. The onset of action is about 3 years and can last up to 60 hours with single dose, depending on what kind of molecules you've chosen. And it is also effective in other non-atopic rhinitis as well. With that, let me touch upon the leukotrienes. Leukotrienes are not new to us. Only thing is the nomenclature came a little later. We were labeling this leukotrienes earlier as a slow releasing substances of anaphylaxis, and then probably we gave them the name assistin leukotriene. And 1990, that was more than 30 years now, we have the drugs available. So leukotrienes are actually cousins of prostaglandins. So what happens with the essential fatty acid in the diet, the lipids are formed, and the lipids in presence of mechanical or chemical stimuli would make arachidonic acid to enter into one of these pathways. So you have cyclooxygenase pathway or the lipoxygenase pathway. The lipoxygenase pathway would lead to release of leukotrienes, and leukotrienes would probably give the phenotype presentation of asthma. So you have all these factors, that is food, infections, allergy, pollens, exercise, cold air, smoking, animal denders, molds, etc., has a potential for stimulating leukotrienes. And leukotrienes are present in so many cells, eosinophil, basophil, macrophages, etc., etc., and they have their effects on smooth muscle, plasma leakiness, eosinophil recruitment, mucosal hypersecretions, and probably airway changes. So logically, if leukotrienes do this, any anti-leukotriene would have beneficial effects, and it will be a bronchodilator. It would treat underlying inflammation. It can be used in all severe classes of asthma and has different but synergistic effects when used with intranasal corticosteroids or inhaled corticosteroids, and would play major role in this comorbid condition. So look at what group of drugs we have. So leukotriene inhibiting drugs are divided into 2. You have leukotriene receptor antagonist and you have leukotriene synthesis inhibitor. So synthesis inhibitor was Xileuton, and leukotriene receptor antagonist was Panelukast, Zafirlukast, and Montelukast. This discussion is slightly pointless because we don't have Zafirlukast and Xileuton available anymore. You have only one drug, that is Montelukast. So you have only leukotriene receptor antagonist drug, Montelukast, available. And you look at the potential of this leukotriene's potency. So if you compare the potency vis-a-vis histamine, it is 1,000 times more potent bronchoconstrictor than histamine, and duration also probably is 10 to 30 times more. Only thing is they are produced in very nano quantity. In the sense, quantity is so small, but otherwise they are 1,000 times more potent. The effect of inflammation also lasts longer, and they are potential chemotactic, in nature. So in rhinitis, if you see, in contrast to histamine, which is primarily responsible for itching and sneezing, the cysteamine leukotrienes are mainly responsible for increasing permeability and vasodilatation and mucosal swelling, and hence probably stuffiness. The stuffiness is due to leukotrienes, and probably that's why anti-leukotrienes, when you use, this stuffiness probably is taken care of earlier. So mast cells, eosinophils, basophils, etc., they release those leukotrienes, which are B4, C4, D4, E4, and all this eventually gets converted into D4, and which is 5,000 times more potent than histamine. So leukotriene production may be important in pathophysiology of allergic rhinitis presentation. So with that, let's look at what therapeutic options we have. We have oral H1 antihistaminics, we have old generation, we have new generation, we have intranasal antihistaminics, we have intranasal corticosteroids, we have leukotriene receptor antagonists, and then we have combinations of all these drugs. So let's evaluate one after the other, what does the literature talk about it. So use of oral H1 antihistaminics in patients with allergic rhinitis, guidelines recommend that new generation antihistaminics that do not cause sedation. You have a very strong evidence for this, a strong recommendation for this. In the sense, we all are aware that conventional antihistaminic, the first generation antihistaminic, would cross blood-brain barrier and will have its effects on various histamine receptors as well, and probably would lead to drowsiness, would lead to sedation, can have complications because of drowsiness, and has some cardiac toxicities as well. And probably with the availability of newer generation H1 antihistaminics, probably there is a definite need to change over from conventional to the newer one. And this is again that should a new generation antihistaminic versus old generation antihistaminic be used for allergic rhinitis? And yes, needless to say that patients with allergic rhinitis, all guidelines recommend that newer generation should be used over old generation. There is very strong recommendation for this. The next question, would this oral H1 antihistaminic in preschool children be used and for prevention of wheezing and asthma? And there was initial thought that if you use antihistaminic in these children, probably we would prevent development of wheezing or development of asthma, and it is proved beyond doubt that that does not happen. And in the sense, probably there is no need of using this particular drug with the idea of preventing wheezing and asthma in them. But yes, it has a role definitely in atopic dermatitis and otherwise in allergic rhinitis, but it does not help you prevent development of asthma. Intranasal H1 antihistaminics, again, guidelines suggest that adults with seasonal allergic rhinitis, there is a conditional recommendation. Again, in children with seasonal allergic rhinitis, that with adult and children both, there is conditional recommendation. Patient with persistent allergic rhinitis, probably this may not be the drug of choice, and the guidelines do not advise us to use intranasal H1 antihistaminics for a persistent or the perennial allergic rhinitis. Newer H1 versus intranasal. That means you have option now of choosing between newer H1 or would you use intranasal antihistaminics. Guidelines suggest that newer H1 rather than intranasal, probably for seasonal AR. In adults with persistent AR, conditional recommendation for newer oral H1, and in children with intermittent or persistent allergic rhinitis, it is suggested that probably oral newer generation may have advantages over the intranasal, though it is a conditional recommendation and the evidence is not great. Oral leukotriene receptor antagonist. We did speak about it, and guidelines suggest that oral leukotriene receptor antagonist in adult and children with seasonal allergic rhinitis is a conditional recommendation, and hence probably your first choice of drug would be intranasal steroids only. In preschool children with allergic rhinitis, again conditional recommendation. In adults with persistent allergic rhinitis, you have a conditional recommendation there also. Should intranasal glucocorticoid be used for treatment of allergic rhinitis? And guidelines say that yes, all guidelines recommend that intranasal glucocorticoids is the drug of choice for allergic rhinitis in adult. Also, it is the drug of choice for allergic rhinitis in children. and in both seasonal and perennial. Intranasal glucocorticoids versus oral antihistamine. So you have a choice. You have a patient and you would use oral versus intranasal steroids, and most of the guidelines say that there is a definite advantage of using intranasal glucocorticoids over H1 antihistaminics in adults and also in children. What about in persistent allergic rhinitis? They say that even intranasal glucocorticoids score over H1 antihistaminics both in adults and children. That means in seasonal or in persistent allergic rhinitis, you would use intranasal corticosteroids over the antihistaminics. This is again intranasal steroids with intranasal antihistaminics. Recommendation that intranasal glucocorticoids rather intranasal H1 antihistaminics with strong recommendation. That means if you have a choice of using intranasal steroids versus intranasal antihistaminic, you would prefer intranasal steroids. Intranasal steroid versus oral leukotriene receptor antagonist. Again, the strong recommendation for intranasal glucocorticoids. So by and large, most of these guidelines are talking about use of intranasal glucocorticoids as a first-line treatment. Then where is the role of leukotriene receptor antagonist? Look at the use in allergic rhinitis with asthma. It is recommended that inhaled glucocorticoid over oral leukotriene receptor antagonist as a single controlling medication. But in patients who prefer not to use inhaled steroids or who cannot use inhaled corticosteroid, or in children, probably you can think of using this particular drug for treatment of asthma in cases of allergic rhinitis. Again, this should be used for seasonal allergic rhinitis. Some patients with allergic rhinitis with concomitant asthma, especially exercise-induced or aspirin-induced, they might benefit from leukotriene receptor antagonist more than oral antihistaminics. In the sense, you would use intranasal corticosteroid, but if patient has got aspirin-sensitive asthma or patient has got exercise-induced asthma, in those situations, there may be some advantages in using leukotriene receptor antagonist. So you would continue intranasal corticosteroids and you would add leukotriene receptor antagonist there. Again, in these situations of perennial allergic rhinitis, the same argument that patient with perennial allergic rhinitis over seasonal allergic rhinitis might use this medicine for a longer period of time because they're symptomatic for a longer period, and hence there may be some advantages using this particular therapy. So where would you, consider leukotriene receptor antagonist place today? Intranasal corticosteroids, first-line therapeutic options. Intranasal corticosteroids are superior to leukotriene receptor antagonist, no doubt. In allergic rhinitis, all meta-analysis say that. Inhaled corticosteroids and LABA are superior in asthma, and leukotriene receptor antagonist is not the first-line treatment even in asthma, but yes, the first add-on, in the sense you have intranasal corticosteroid and patient is not doing well, you have choice of intranasal antihistaminic, oral antihistaminic, and leukotriene receptor antagonist. Probably leukotriene receptor antagonist would score over other therapeutic options, and this is again seen in various clinical trials where it talks about utility of Montelukast in seasonal allergic rhinitis, perennial allergic rhinitis, and children with in adults as well as in children as the first add-on therapy, and probably this being a tablet would take care of systemic inflammation and would take care of even the lower respiratory, and the additional upper respiratory tract inflammation will be taken care of by that. Same thing with asthma and allergic rhinitis in children and in probably children which are slightly older. To conclude, I will give you answer of all these three questions that Naishad, who has probably allergy-induced asthma, exercise-induced asthma, or exercise worsening asthma in case of allergic rhinitis, otherwise very well managed on intranasal corticosteroid, and as has to perform some exercises tomorrow, I would recommend addition of Montelukast. So Montelukast doesn't work so fast. It's not a drug of choice for acute scenario, but it has some role in the preventive thing. Mona was young lady has allergic rhinitis with bronchial asthma. She's on intranasal corticosteroid. She's on inhaler, and for additional control over symptom, the first add-on I would consider is Montelukast. And in children who probably there is reluctance in giving them inhaler, there are issues with their compliance, there are issues in delivering those drugs, there are issues in parents' understanding, and probably where you are also not too clear about diagnosis, you may consider Montelukast as a drug there. To end this presentation, I thank you very much, and I would end with this famous quote. Actually, it is not famous quote, it is my personal quote, yet to be famous. And it says that sneezer should not be allowed to wheeze, and wheezers should not be left to sneeze. And probably in situation where we are talking about allergy rhinitis management, intranasal corticosteroid would score over all possible therapeutic options. But the first add-on therapy that you would consider in patients with both seasonal allergic rhinitis, persistent allergic rhinitis, or perennial allergic rhinitis would be Montelukast, in my opinion. Thank you very much for your patient hearing.
Good evening, everyone. a warm welcome to this webinar. Myself, Dr. Giriraj Bomma. I am from Gulbarga, Karnataka. I'm a practicing interventional pulmonologist. So today my topic of discussion today is, what is the role of antihistaminics in allergic rhinitis? And when we combine this anti-leukotrienes to this antihistaminics, what is the dual combination role in allergic rhinitis? So we are discussing today, and the questionnaire will be open today. So next 15 minutes it will be there. So why we are more concentrating on this allergic rhinitis? It's very, very important because in Indian population, if we see the allergic rhinitis, it is the prevalence rate in the adult population. It is around 30% of the adult population, they suffer from this allergic rhinitis. And in the pediatric population, around 40% of the population, they suffer from this allergic rhinitis. Hence, it needs to be studied in detail. Next slide, please. Next one. Okay. Okay, this is a 40% of the pediatric population. Next slide, please. Now, what is the definition of this allergic rhinitis? Allergic rhinitis, it is an IgE, antibody-mediated inflammatory disease that is characterized by one or more of the cardinal symptoms. There are 4 cardinal symptoms they have given, like nasal congestion, rhinorrhea, sneezing, and itching. One or more of these symptoms can be present. All of the symptoms may or may not be present in this allergic rhinitis patient. So now next slide. So now very, very important about this allergic rhinitis we need to know is the pathophysiology. It's a very complex mechanism is involved in the pathophysiology of this allergic rhinitis. But as the time is very less, we have made it very simpler manner so that the mechanism of the action of the drugs accordingly is very, very important. Don't change this slide, please, because see, the mechanism of the pathophysiology of this allergic rhinitis here, it is divided into 2 phases, early phase and the late phase. See, the early phase, what happens is whenever the aeroallergen exposure it is going to occur, the antibodies are produced. Simultaneously, the aeroallergen that is going to bind to this mast cell, and hence the sensitization of the mast cell occurs and degranulation occurs and the histamine is released. This can occur in any person and any patient it can occur, and hence this histamine, it causes sneezing and itching and little bit of rhinorrhea it can cause. We call it as the early phase of reaction. This is very important. This can last to at least up to 5 to 6 hours also. So this can occur in any persons or any patients. Now, this is the early phase of reaction. Now, if these symptoms are prolonging more than 7 hours and this repeated insult is occurring to the patient due to this aeroallergen, now it becomes a chronic, repeatedly or more than 7 hours it is occurring, then what happens is, along with this, now the mast cell again it goes for the degranulation, along with this histamine, other chemotactic factors like leukotrienes and other prostaglandins and other minimal chemotactic, minimal inflammatory chemotactic factors like eosinophils, basophils, cytokines, they are also released. But the notable factor here is, here also the leukotrienes like interleukins, they are also released. They are 5,000 times more potent as compared to the histamine. Hence, here the word inflammation comes to the existence. Previously, here histamine was causing the sneezing, rhinorrhea and all those things. But once the leukotriene comes into the existence, the inflammation makes its place. Once the inflammation comes, now all the itis starts, like bronchitis, then bronchoconstriction, and finally it may also leads to bronchial asthma. So guys, that is why it is called as the late phase of the reaction. So we need to know this pathophysiology of this allergic rhinitis. It is divided into the early phase and the late phase. Next slide, please. So frequency of the allergic rhinitis symptoms in the Indian scenario, which is considered to be as the chronic, they have taken. So next slide, please. So nasal obstruction and the congestion, they have taken it as to be the considered to be the severe symptoms and moderate to severe, and if they are persisting If they are persisting, if they are the seasonal, if they are the perineal, they consider to be the severe symptoms in the allergic rhinitis. If they are presenting 1/3 of the patient of this allergic rhinitis, they consider these symptoms are the severe symptoms, and hence they have to be taken variously and dealt to be dealt to be seriously. Next slide, please. So if untreated can lead to various problems. Next slide. Next one. So leading to the comorbidities. Yes, next one. Next. So it leads to various like comorbidities it will lead to. Next slide. So as this slide is very important, see many of our bronchial asthma patient, if you dig the history, about 70 to 80% of the patient, they tell their first cardinal symptom started with the nose, that is they started with the rhinitis. That is why it is very, very important to control it to the nasal level only or at the rhinitis level only. It has been studied that 6 to 85% of the patient with the asthma, they do have the rhinitis. That is why the rhinitis has to be controlled at the initial level only. Next slide, please. So how do we manage this allergic rhinitis? Very interesting. Avoidance of the allergen. They have been divided, like how we are going to manage this. Avoidance of the allergen. As we know, friends, as it is an aero allergen, after all, we try to avoid this allergen, but still as it is an aero like pollens, danders, or the dust mites, still it attacks to the, it leads to the exposure. So hence it causes the rhinitis. That second thing is pharmacotherapy. Various drugs are available in the treatment of allergic rhinitis. Today we are dealing with the two important drugs which are used in the treatment of allergic rhinitis. And the third and the last one is immunotherapy. So the next slide. Yeah, here is a very important take-home slide. We can say the pharmacotherapy for the allergic rhinitis. See here they have taken the symptom-wise and how the drugs have affected or they have given their action in the different symptoms they have systematically classified. Here if you take the antihistamines, anti-leukotrienes, they have given the beneficial effects. Even they have included here the ocular symptoms also. If it is not included in the allergic rhinitis symptoms, they have considered the ocular symptoms also. So antihistamines, anti-leukotrienes, and corticosteroids, they have given the beneficiary effects. But the corticosteroids, if they are not used at the long term, here the promising molecules, they stand to be as the antihistamines and the anti-leukotrienes. So this slide is a very important slide according to me. So various symptoms they have noted and how these drugs have acted there. So very important. Next slide. So what is the role of antihistamines in the treatment of allergic rhinitis? H1 antihistamines turn off the H1 receptor and prevent its activation by histamine. H1 antihistamines are particularly effective in relieving histamine-mediated rhinorrhea, itching, sneezing, and vasodilation. When used as monotherapy, H1 antihistamines should be administered continuously while symptoms are present. See, first generation H1 antihistaminics, now they are out of this thing, what you can say, out of this thing usage because of this CNS side effects as they cross the blood-brain barrier. But now at the highly recommended usage, the second generation antihistaminics like levocetirizine, fexofenadine, belastin, loratadine, desloratadine, because they do have the less side effects as compared to the more less side effects as compared to the first generation antihistaminics. So they have taken the place of the first generation antihistaminics. Here we will discuss about one of the second generation antihistamine. The next slide, please. Yeah, next slide. Yeah, second generation antihistamines such as fexofenadine can improve the allergic rhinitis symptoms with minimal side effects. See, here they have taken the fexofenadine because they see that the second generation antihistaminics, if you take like the commonly available levocetirizine and desloratadine, they too have the minimal side effects. Like if you say the sedative effects, if you compare with the fexofenadine, they too have the minimal sedative effects. But fexofenadine comparatively, in the next slide, yeah, here the fexofenadine safety and efficacy they have compared with the loratadine. They say that it is a fantastic drug if it is used like when compared to the other second generation antihistamines, but they too are very good drugs. But the patient selection here lies on a very important, where has to be used, which second generation antihistamines have to be used. Here we are discussing the very safe drug, that is fexofenadine. Next slide. Now, what is the role of anti-leukotrienes in the treatment of allergic rhinitis? See, leukotrienes are released during the early and the late allergic inflammation of the nasal mucosa, mast cells and the eosinophils. Many nasal symptoms of edema, congestion, secretion and infiltrations are mediated by this chemical. Currently, only cysteine leukotrienes, cysteine receptor antagonists are recommended as add-on therapy of allergic rhinitis. Here with us, many anti-leukotrienes are present, but we are widely using and the available drug is a montelukast, which is best studied, and it has been added in most of the cases and even in the moderate to severe persistent diseases. Next slide, please. Okay, next slide. Okay, montelukast is studied very well here because it's very important add-on therapy drug. So it is a mode of excretion is biliary, half-life is 5.5 hours. Plasma protein binding is 99%. To reach the maximum plasma peak concentration is 3 to 4 hours. Next slide. So here the placebo along with the montelukast, they have studied. It has a drastic reduction in the eosinophils. They have taken a study. It has gone into the minus 0.1. The trials have been taken. It has drastically reduced the inflammation. Very much important is the inflammation. Inflammation. Montelukast, inflammation. It has been related to inflammation. Very important. Next slide. Okay, see, again the montelukast with the placebo, various studies have been conducted. Montelukast has given the very much better efficacy. The message which has to be taken is montelukast is, it gives a very much good quality of the life as far as the inflammation is concerned. Next slide, please. Okay, see here the 6 weeks, trials have been taken. Again, they say that montelukast has scored a very good score when compared to the placebo. Various type of the studies have been conducted. This is also one of the 6-week study that has been conducted on the adults with the 10 mg, and they found it to be very useful. Next slide, please. Now, why a combination is required? Very, very important, my dear friends. So today's topic, why a combination is required. For that, again, we need to go for the pathophysiology. Next slide, you can. Next slide. Yeah, see, and before this, yeah, mode of action. We'll come to the mode of action only. As I already said, early phase of the reaction and the late phase of the reaction. See, early phase of the reaction, what is releasing is a histamine is releasing, and the late phase of the reaction, what is releasing is a leukotrienes. Various type of the chemotactic factors are releasing, but we are more concentrating on these leukotrienes. They are like various type of the interleukins. As I said, these leukotrienes are 5,000 times more potent as compared to the histamine. Hence, these leukotrienes are to be dealt very seriously. Hence, this montelukast is a promising drug. When combined with the fexofenadine, both the early phase and the late phase, both are covered here only. And hence, the symptoms are very much bad at the early stage only. So my dear friends, here one thing we note here is as the inflammation is coming, I'll come to that point. Since montelukast is proving to be a very promising molecule, here the two symptoms are noted here: nasal congestion, that is stuffy nose, and the inflammation. That's a very, very bad symptom of this allergic rhinitis is dealt with the montelukast only. So next slide, please. Next slide. Okay. Comprehensive treatment. That is, as I already said, combining these two drugs, both the early phase reactions and the late phase reactions, both are dealt with. Next slide. Next slide, please. Okay. Okay. See here, the combination study has been done very beautifully. The 21 days of the trial, the fexofenadine with the montelukast, and fexofenadine with the placebo, 120 mg of fexofenadine along with the montelukast 10 mg in the adults they have studied. They do have the nasal turbinates along with the stuffy nose they had. Then the duration of the 21 days trial had been taken. Then after the 21 days, the drastic study was being taken. The drastic results has been observed in both the groups. There is the next slide you can see. Next slide. Yeah. See, this is a placebo group. Next one is a placebo group. With the montelukast group, here we can see the drastic decrease in the nasal turbinates along with the stuffy nose as compared to the placebo group. Hence, the montelukast adding really proved to be a promising. Hence, a combination is very important. Next slide, please. Okay, the same, adding a montelukast proved to be promising after the 21 days of this trial. Yes, next slide, please. Here, the conclusion is leukotriene receptor antagonist antihistamine combination therapy is more effective than the antihistamine alone in the control of allergic rhinitis symptoms. Next slides. Yeah, what is the area recommendations? That's also very important. Next slide. They too recommend at the late phase of the reaction, we have to add the leukotriene receptor antagonist to the OHA. We have to use. And the next slide, they even say once the bronchoconstriction, the patients are going, when the inflammation is going, adding the leukotrienes, definitely, anti-leukotrienes definitely is promising. It has to be added once you know that the inflammation is going on, once the late phase reaction has started. This is the area recommendation. Next slide, please. Okay, another study in the 2018, that is Otorhinolaryngology Head and Neck Surgery Foundation. It has been conducted in 2018 only. It's a meta-analysis. They too have conducted this study, oral antihistamine alone and combination. What result has given? The fantastic result. They conducted it in a perennial allergic rhinitis. It was a long-term study. Many patients are involved in this. So fantastic results. They found out in a perennial allergic rhinitis. What was the result of this? They found out to be very beautiful result in the perennial, particularly in the perennial allergic rhinitis. Next slide, please. Okay, they found out to be, these are the results, very complex, looks very complex. So what is the final outcome of this is, next slide. They say that after this, next slide. They say after, next slide. So the outcome of this meta-analysis, next slide. Okay, the outcome of this meta-analysis in the perennial allergic rhinitis again proved to be very promising. Like the current evidence suggests that compared with H1 alone, the combination of LTRS and H1 increases efficacy for daytime and the composite nasal symptoms, including rhinorrhea, sneezing, and itching in patients with AR. Patient with perennial allergic rhinitis could benefit more from the combination therapy. See, they are concentrating on the perennial allergic rhinitis because it was a long-term study, meta-analysis, including the many patients. Next slide. So, my dear friends, say here we have discussed and we have taken the many studies. Now we have seen the single drug and its action differently, and what is the effect of this combination of this drug. Now I just want to say that as the early phase reaction starts, once the repeated insult occurs, there will be a hidden inflammation that is going to start. Hence, once the inflammation that starts, there will be this hidden inflammation. Once it starts, as the histamine is releasing, along with that leukotrienes are also releasing in the early phase itself, not in the late phase only. We should not wait till the late phase. As we say moderate to severe allergic rhinitis, I say before to that moderate allergic rhinitis only, the adding the montelukast will be definitely promising to this antihistamines, because once this inflammation makes a marker, it further leads to a very bad consequences like bronchoconstriction, and even it may lead to a bronchial asthma. And even it has proved to be a very promise dual combination therapy in perennial allergic rhinitis, seasonal allergic rhinitis, and repeated allergic rhinitis patient. Don't give only a single antihistaminics. Combining with anti-leukotrienes proved to be a promising, both in the early and the late phase symptoms. And anti-leukotrienes definitely have helped in combination with the antihistamines. This should be a take-home message. As early as the anti-leukotrienes are added, it is better. So thank you very much. So now the question is, this thing is open for you. So the doubts can be asked. Thank you very much for your patience.
Shall we start? Are we there?
Yes.
Yes.
Okay.
Yes. Yes. Yes.
I would like to thank Dr. Giriraj Bomma for a wonderful talk right now. And the thing is, we're already a bit low on time, so I think we will proceed to the question answer session. So we have quite a lot of questions. I think we'll start with Dr. Agamora, sir. So, sir, the first question asked is, does deviated nasal septum cause allergic rhinitis?
Thank you, Dr. Tony, for that question. And I thank those thousands of doctors who found time today on Saturday evening to log in and discuss about the management of allergic rhinitis. I thank Dr. Giriraj for giving that wonderful presentation on antihistaminics. And this question is very pertinent. In fact, a lot of doctors, a lot of patients also do ask us about their query on DNS. Trust me, DNS has got nothing to do with allergic rhinitis management. If you really carefully look at nose, I'm sure 90% of your patients, if I may be underquoting, 95% of the patients will have a deviated nasal septum. And the way I talk to my mind, or the way I try to convince my patient, is deviated nasal septum would mean probably there is some space which is more on one side and less on the other side. The overall volume remains the same. The air overall going remains the same. I would consider taking ENT evaluation for those patients of allergic rhinitis where there is more of nasal obstruction, where there is a lot of purulent discharge, or where if I get chance to do the radio imaging and I see a lot of mucosal thickening. Only those patients probably I would send for ENT evaluation. The rest of the patients does not require any management of deviated nasal septum.
Okay. Okay, sir. And so another question that has come is, how long once you start a nasal spray combination, let us say acetylene and fluticasone, how long do you give as one stretch for a treatment course? And secondly, in general, how long will you continue and prolong the courses of nasal sprays?
Dr. Tony, would you also tell me who's asking this question? Do you get that on screen? The doctor's name, is it evident? Is it readable on screen?
No, that actually 2-3 people have asked the same question. Sir, coming 1 second. One is Dr. Sudeshna Ghosh, who has asked this question. Another is Krishna Kumar Mishra.
Hi Sudeshna, hi Krishna Kumar. These are very relevant issues. You spoke about how long should we continue antihistaminic, as probably was very well conveyed by Dr. Giriraj, and probably I also tried to put it in my slide. Inhaled corticosteroid is the mainstay of treatment, and you would consider antihistaminic for the rhinorrhea part of it. The running of nose is taken care by antihistaminic. Second, antihistaminic works faster, and steroid will take little longer. Montelukast will take even longer for its action, and hence there may be some sense in combining it with antihistaminic treatment, be it oral or be it intranasal antihistaminic. So what I would prefer in my practice is you start with those combinations. Once patient improve, that means most of the time your intranasal corticosteroids and your montelukast would take care of the symptoms in next about 2 weeks time. At that time, you withdraw antihistaminics and continue inhaled probably intranasal steroids after that. How long would you continue is a very interesting question. It depends on if you're able to identify the allergen. Suppose if there is IgE mediated, suppose you have a pets in the house and you can get rid of that pets, probably you would continue this medicine for 3 to 6 months after those pets are taken care of, and then you may withdraw this medicine. But if you're in situation you may not be able to find out, say you have a leaky house, you have probably some industrial thing going on, there is a farm there and probably exposure to pollen keeps on happening, and you're not in the position to control environment there, you're not in the position to change your houses there, you may have to continue this treatment indefinitely. We have enough evidences to talk about its safety when used for a longer duration. But so as I said, antihistaminic for a shorter duration. I learn it from my skin and dermatologist colleagues who continue antihistaminic for a longer duration. I never felt as a chest physician that we require antihistaminic over a longer duration. Most of these cases, I'm sure Dr. Tony and Dr. Giriraj would agree to me that most of clinical scenarios that we come across as chest physician, antihistaminics can be withdrawn after a short duration. That means after about 3 weeks to 6 weeks, max about 1.5 months, you would continue that and withdraw, and continue your intranasal corticosteroids for 1 year at least. Continue your montelukast for 1 year at least. Tony, do you see, is Krishna online? Dr. Krishna probably didn't come in the initial part. Do you see on screen? Is he there online? Krishna, are you there? Or say hello message at least.
No, in this view, he will not come. It's only us, the speakers who are there in this
Okay.
right
I can
now.
send him the link. I can ask him to come online. Okay, you please continue. Yes.
Yeah. Okay, then I would like to ask Dr. Giriraj a question. Dr. Giriraj, Dr. B.L. Butra, doctor has asked, what is the role of ketotifen in allergic rhinitis?
Okay. Ketotifen basically it is a second generation antihistaminic and also a mast cell stabilizer. Okay. So it has been studied in the various papers that like 3 months duration and a 4 month duration also it has been studied. 3 months duration and 4 months duration also it has been studied. Then what happened is the reversal of the symptoms effect has been seen. So ketotifen being effective during the period, but the reversal of the symptoms has been seen during the usage of this ketotifen. It is being better used with the fumarate. Ketotifen fumarate is used. But because of the reversal of the symptoms immediately after the withdrawal, it has been seen with the ketotifen. Hence, it is being not widely used as an antihistamine now. So other drugs can be used, and ocular symptoms in the I see the conjunctivitis, the ketotifen is mainly much used according to me. In the allergic rhinitis, I prefer the other antihistaminics to be used.
Thank you, Dr. Giriraj. That's a very simple answer. And I would have there is actually a question that has come connecting to asthma. And since we deal with that, I think we can approach that question too. Question from Mr. Jay Kishan. An athlete having exercise-induced asthma is not willing to take inhaled steroids for fear of positive dope test because of steroids. How do we approach such patients?
No, very interesting question. Is it Dr. Jay Krishna, right?
Jay Kishan.
Jay Kishan. Okay.
Yes.
Dr. Jay Kishan, I used to think that exercise-induced asthma is common. But I realize that exercise-induced asthma is not really common. It is most of the times exercise worsening asthma. In the sense, your patient is asthmatic, he is symptomatic, but he's kind of used to living with that asthma. So when you investigate those patients, when you do the spirometry, you realize there is definite amount of obstruction there. There is definite amount of reversibility. The patient is not symptomatic for that. And when he does exercise, he only realizes, he only perceives that asthma during that exercise, and that is exercise worsening asthma. Real exercise-induced asthma, when I was interacting with a lot of pediatric friends, they said it does happen, especially when children, they are playing on grounds like the hypothetical case that I showed you, the first case that I presented. That's a situation where patient may have some allergic rhinitis, patient may have mild intermittent asthma, and when they run, when they jog, when they are on grounds, when there is dust exposure, they may get this worsening. Actually, these patients are not the ideal candidates for Montelukast therapy. In those situations, probably it is still wiser to give them inhaled corticosteroid. It is still wiser to give them inhaled intranasal steroid if there is associated allergic rhinitis. You would give this exercise-induced, the drug for exercise-induced asthma, Montelukast may score. Montelukast has a definite place when it is purely isolated, exercise-induced asthma. Probably it is psychological, stress-related asthma where your vagus probably, mediating in the pathophysiology of asthma. And those few scenarios, you would consider using Montelukast as a drug of choice. Now, I would probably start Montelukast 3 or 4 days prior to the planned exercise. Suppose my child is going to take part in the running competition in school. I may start him on Montelukast 3 or 4 days prior to that particular episode. So most of the guidelines now do not talk about it. This is what was the understanding when we kind of introduced Montelukast to Indian market, and probably 2005, 2007, 2008, we had this kind of understanding. But now we feel in most of the situations, you would manage them on inhaled corticosteroids and the aerosol and the intranasal corticosteroids. Thank you, but that's a very interesting question. And your second part, most of this time when you give these inhaled corticosteroids in the dose which are mentioned, you don't pick it up on blood test because hardly any dose is absorbed. So there is no systemic probably elevation of steroid levels, and hence your blood levels will not really come in the way. Thank you.
Thank you, Dr. Agambora. And Dr. Giriraj, there are two questions which I would like to merge. One question asks us about fexofenadine It's more like what are the side effects that we can expect with prolonged use, or in which scenarios are we supposed to be more careful with the use of fexofenadine? Usually, for example, I usually take care, I'm very particular about the elderly patients and usage of fexofenadine. So that way, and along with that, bilastine claims to be safer. How would you compare that with fexofenadine in the same risky category?
Okay. So this very interesting question, sir. Because fexofenadine, we have seen, sir, it is very safe if you compare to the other second generation antihistaminics, because it can be used in the younger generation, first thing, and second thing, it can be given in the working population, because its safety profile, if you see, it's non-sedative. First of all, it's comparatively safety profile, if you see, it's totally non-sedative. And the second thing is, as you said, in the elderly population, the hepatic monitoring we have to see, sir, because the liver function test derangement can occur if you give it for the long-term usage. So as the Agam sir already told, as far as possible, the antihistaminics should be withdrawn as early as possible once the symptoms comes under the control, and we should continue the intranasal corticosteroids for the long term, and even the montelukast should be continued for the long term. And regarding the fexofenadine in pregnancy also we can use, and as required it can be used. I mean to say, if it is very much essential, it can be used, but in the lactating mothers it cannot be used, and the hepatic and the renal impairment, much studies are not available. So less than 6 months the safety is not available. So like this. And your second part of the question, comparison of the fexofenadine along with the bilastine, not much studies are available, but till now the fexofenadine is scoring very well. If you compare with the bilastine, still the fexofenadine usage is very well, I can say. But the dermatological issues, if you compare, the bilastine is scoring very well in the dermatological patients. But as far as the allergic rhinitis is considered, the fexofenadine is scoring very well, sir. Yes, sir.
Thank you, Dr. Giriraj. And Agam sir, actually there is a direct question for you. It's from Mr. M. Gangadhar. He's asked as to, he's actually told you had a very fantastic talk as usual. And his question is, what would be your antihistamine of choice in pregnancy?
Difficult question. Antihistaminic of choice in pregnancy. Thank you very much for your compliment. I'm really touched by your comments I'm very happy that you liked my talk. Regarding antihistaminic of choice in pregnancy, most of this, as you know, now there are ethical issues in doing studies with drugs. Earlier time was different, but now we cannot study any drugs there are issues in studying drugs in pregnancy. There are issues in studying drugs in younger children, etc. So we don't have enough experience with newer molecule. If you ask me which molecule I would use, I think I would use levocetirizine. I've been using levocetirizine in most of the situations. I would avoid first generation antihistaminics so far as possible, though we have used first generation antihistaminic for a longer time. But since we have better drugs available, since we have safer drugs available, I would refrain myself from using the previous generation molecule. I may use some of the previous generation antihistaminic if patient has got associated issues. Say I have a pregnant lady with nausea and vomiting, I would use antihistaminic which has got action, which is anti-nauseating or which is anti-emetic action. So I may use those drugs. If I have a patient who's not getting good sleep because of, say, whatever issues, I may consider using first generation antihistaminic in very, very niche indications like this. But in most of the situations, if required, I would try to use levocetirizine there. Though literature says that probably fexofenadine and bilastine may be used, but I think bilastine is very new molecules. I would not be comfortable using it in pregnancy, at least as of now. We would get wiser as time goes. Now, second thing is, so far as possible, we should try to avoid all oral drugs in pregnancy. Now, if you have a situation where you have to use antihistaminic, we are talking about a couple of situations. The patient has got severe skin disease, patient has got severe allergic rhinitis, patient has got maybe drug reactions and allergy. There you may use it for a very short duration. When it comes to allergic rhinitis management in pregnancy, I'm very certain in my mind that I would not use antihistaminic. I would use intranasal steroids and I would use inhalers which would take care of my bronchial asthma at the same time. I would use combination inhalers, that is one beta agonist with steroid combination and one intranasal steroid. And I would strongly recommend not to use antihistaminic in pregnancy. Thank you.
Thank you, sir. And sir, now there is again a question by Dr. Amitash. He had missed a part of the talk of which you of your part of your talk. So his question specifically is, now that we know about the some new studies are showing about new side effects seen in the use of montelukast in basically neuropsychiatric line. So what is the situation where we try to continue the treatment with that despite that risk? Though as far as I know, in India we have not seen much of these side effects. This has basically been seen only in the UK. Here we use it. I use it a lot, and I've not seen as such not a single patient today has had a side effect based on the montelukast usage. So I don't know if it is a problem with the salt combination of the one used in UK and the one used in India. But sir, I would like both the speakers to enlighten on the application and what we look out for in the category of patients. And is there any particular category patients where we try to avoid montelukast based on this finding, which is new?
Dr. Giriraj, would you answer that question first?
Sir, according to me, the montelukast I consider to be as the very safest molecule in my practice, because compared to antihistaminics, also I prefer montelukast to be used, because it controls the inflammation at the very early and the late phases. So montelukast is rampantly used in the practice. I think everybody uses it, and we have used it to the long-term extent. I think in the Indian scenario, maybe we haven't studied the psychiatric scores, I think, and we haven't identified. Maybe that is the reason the side effect profile may be there, but I don't think the neuropsychiatric disturbances are so much observed in the Indian scenario. It is my practice says the montelukast can be safely used. It's a wonder drug, I can say. This is my experience. Yes, sir.
Excellent. I also completely agree to Dr. Giriraj. And in my also experience, I have not come across any situation where I had to stop montelukast for whatever side effects. There are some patients who do complain about slight dizziness, slight, myalgias kind of issues. And that is the reason why most of us use this particular drug in the evening. There are, yes, recent case reports which talks about suicidal tendencies and probably some serious side effects which are observed across the globe. But in India, we have not come across many situations. To the extent that we have one school of thought in India where people feel that montelukast is as good as water and it is completely useless. There are some doctors, when I interact with them, they find the montelukast probably one of the poorest add-on therapy in situations where your inflammation is not under control. And I would buy their point to some extent, because all the other products, if you see in that category, you look at Xileuton, you look at Perineal, etc., which are the other drugs, did not stand the test of time. If you look at other PAF inhibitors also, which came like Seretodast, and there was one more molecule, I forget the name, none of those molecules probably stood the test of time. If we look at the pathophysiology, Seretodast must come above the montelukast, in the sense when there is a cyclooxygenase pathway and the mediators are being released, the PAF would come above that. So if you use this, it would stop inflammation right at that level. And if that is the situation, you need not use antihistaminic or you need not use montelukast. That was the understanding when Seretodast was introduced. But in practice, we did not see that happen. So many a time, the literature and clinical evidences do not match. I would say, in a nutshell, one of the safest tablet that I've come across in the management of asthma would be montelukast. When it comes to oral therapies, your beta agonist, say you take salbutamol, you take any of these tablet beta agonists, they would have their own side effects with tachycardia, and that would be seen in most of your patients. You take phosphodiesterase inhibitors, and we know that there is a very narrow safety margin, and that's why probably those drugs have taken backseat when it comes to guideline-based management of asthma. You talk about steroids. Steroid has got plenty side effects when given over a long term. But when it comes to montelukast, fairly safe in my opinion. I completely agree to Dr. Giriraj's view on that.
Thank you, sir. And sir, now we have almost it's more an entire patient case has been given. So do you both mind if we go into one case?
Yes, please go ahead.
Okay. So this is by Dr. Kuljit Singh. The question is actually directed to Dr. Agambora. The question is, 30-year-old patient operated at the age of 12 for nasal polyps, was asked to go for cetirizine later after diagnosis with the AR, and later, it is at 10 years later, at the age of 22, diagnosed with asthma. Now patient doesn't know what medicine to use, as it's always still continuing with perineal sneezing, severe nasal congestion, where the nasal turbinates are there in a single nostril, and asthma is not so severe. So how to handle the nasal turbinate issue with the AR, as one nose is permanently blocked for the patient despite polyp surgery in childhood. Asthma is not so severe, again repeated, and patient has seen both chest physicians and ENT specialist and now is stuck.
That's a very common scenario that we come across in practice. Most of this, there is a myth in mind that if you get surgery done, your asthma will be under control, your allergic rhinitis will be under control, but we need to clearly understand that this particular thing is a complication of allergy. You are just taking care of the complication. You will not be able to take care of allergy by doing surgery. Allergy is generally a genetic, issue, and you can't really alter your allergy pathways. So what happens? You have frequent allergies. That allergy leads to probably polyformation. That allergy leads to mucosal thickening, and that leads to a lot of headache, a lot of heaviness, a lot of frequent infections there. You would operate upon this patient if there is great feature of obstruction, in the sense if there is heaviness and if there is more of headache, you would consider this patient for surgery, but otherwise none of this patient requires surgery, especially with excellent intranasal steroids available. If you give this treatment regularly, even the nasal polyps do shrink over time. Even the nasal turbinate hypertrophies which are there, which go back and reverse to their normal anatomical structure over time. If you can convince your patient to take treatment properly, and if they are compliant enough to treatment, surgery is required in very small proportion of patients. So what happened is, in early childhood, this patient was subjected to surgery with the hope that he will not develop asthma, which was a myth. And in fact, we did have that kind of understanding a couple of years earlier, that if you treat sneezing early and if you put them on antihistamine, they will not develop asthma. And I did show in one of my slides that this was a myth. We have concluded that that understanding is completely wrong. And as you can see in this particular child, he had allergic rhinitis, he had nasal polyps. Even after undergoing surgery, he did develop bronchial asthma, over time. This bronchial asthma is not severe enough. Patient has got predominantly allergic rhinitis phenotype, and hence your treatment focus should be on allergic rhinitis only. I would prefer to put this patient, if he presents to you in acute exacerbation state, treat with antibiotics, treat with oral steroids, treat with intranasal steroids, treat with antihistaminic together. After about short course of treatment with antibiotics and steroid, you withdraw oral steroids, withdraw oral antibiotics, continue them on inhaled, probably intranasal steroids, continue them on oral, antihistaminic. If required, you may continue even intranasal antihistaminics. You may add Montelukast at this stage once infection is over. And then as time goes, probably next 2 to 3 weeks time, I would remove antihistaminic part of it. I would continue them on intranasal steroids and Montelukast. I would continue it for 1 year. Luckily in India, we have 3 particular seasons, and we need to understand the change in behavior with each change of season. So I would continue this treatment for 1 year. At the end of 1 year, if patient is completely asymptomatic and if his parameters are otherwise fine, I would think of de-escalating it further. Would continue for another 6 months or then probably stop it. In very small proportion of patients, you would actually be able to get rid of this therapy. But in most of the patients, you may have to continue for a longer period. Thank you.
And so, Dr. Giriraj,
Yes.
there is a question from Mr. Praveen. Is there a role for monotherapy with Montelukast when the patient is asymptomatic?
Monotherapy with
Montelukast when the patient is asymptomatic. So probably after the treatment is over, after the exacerbation phase.
Oh, okay. Okay, sir. Okay, sir. See, when the patient is, for example, the allergic rhinitis, we very much classify them into mild, intermittent, moderate, and severe, sir. Once the patient is in a severe, moderate to severe condition, okay, the combination is required. Once they go on to the improvement therapy, step-down therapy, yes, we consider them step-down therapy as already sir said. We remove the antihistaminics, and then we can only give monotherapy with the Montelukast and along with the intranasal corticosteroids. Only monotherapy with the Montelukast, definitely it has given some benefit, but along with the intranasal corticosteroid is must, sir. Only monotherapy? No. It has reduced to certain extent, but only monotherapy with the montelukast has not helped, sir. But it has to be combined with the intranasal corticosteroids with the step-down therapy. Dr. Agam sir wants to add something. Yes. Sir. Yes.
That's a fantastic point. When it comes to monotherapy with leukotriene receptor antagonist, it is not indicated. So most of the times you will have monotherapy if your patient is asymptomatic. You will continue them on intranasal steroids, or you may continue them on inhaled steroids. Or now the recommendation are with new GINA updates, you will put them on combination. In the sense, you will put them on pharmatol with budesonide or pharmatol with whichever steroid you like as the inhaler, one common inhaler for asthma management. There may be some practical situations where you may put patients on monotherapy with montelukast, and I will tell you that. If you have a child where probably drug delivery is a problem, if you have a child who's getting frequent allergic symptoms and you cannot put them on antihistaminics, these are the situations where you may think of putting them on montelukast. Montelukast is available as 4 milligrams, 5 milligrams, and 10 milligrams. And luckily, it is not actually related to weight of the patient. It is generally given as per the age of the patient because it has to do with the leukotriene receptor density and not which is not weight adjusted. You have many a times a situation where you may have to use montelukast. Say, imagine a situation you have a patient of disease upper respiratory tract. Say you have a patient of malignancy there. You have a patient where drug absorption is at fault. I had a patient where there was a mucor in the sinuses there. So you will come across such infrequent situation, maybe once or twice in your lifetime, where you may have to consider only monotherapy with montelukast when you're talking about treatment of upper respiratory involvement. So these are very few situations, but most of the times, as Dr. Giriraj said, you will not come across a situation where you have to use montelukast alone. Nice. Thank you.
Thank you, sir.
Thank you, sir.
Thank you.
Sir, and one question I think most of the parents who are watching will be interested to know is that at how small an age child is it safe to initiate nasal sprays?
Nasal sprays, I'm not too sure. Probably drug absorption, etc., is a problem in early childhood. I'm not too sure at what age we have the recommendation, but montelukast you can start 2 years on, no, first year onwards. After 1 year onwards, you could start this montelukast. I'm not too sure about intranasal, how soon you can start it. Dr. Giriraj, do you have any idea about it?
Sir, intranasal corticosteroids, even I don't know, but montelukast more than 6 months we can start, sir. That combinations, safely some articles have given more than 6 months. You can start along with the antihistaminics, you can start the montelukast, sir. But again, the intranasal corticosteroids, even I don't have much idea about that, sir.
Okay.
Yes.
So then better if I think it's better to go with oral therapy rather than, because even probably the technique of inhalation and the nasal delivery might not work well in small children. So it makes preferable to go with.
And I just Googled it, and it says that probably you may begin as early as 18 months. That is somewhere around 1.5 year. So Google shows on Medscape the article, which is July 2017, talks about at 18 months you can start intranasal therapy. Good.
Okay. And sir, there is a question. I think I'll give it to Dr. Giriraj first. That from Ms. Gurleen Kaur, that fexofenadine is showing symptomatic QTC interval prolongation.
Yes, sir.
And so, how many cases have you seen of that type? But I would also like to add on to that in the present corona situation, as we are using HCQs as a line of direct treatment in every level of care, and we know that it has the same side effect. So I would like to make it a combined question that if fexofenadine is already ongoing in a patient who is then diagnosed with corona and we have to end up giving HCQ, or the next patient who is having new symptoms at that point of time, and do you combine both? Will you combine fexofenadine along with this thing, or what do you do in that situation?
Sir, in such scenarios, I prefer already the HCQs. If the ECG, if the cardiologist, they say cardiologically the patient is not safe to give these drugs, sir, then I prefer to withdraw the fexofenadine, and I prefer to give the like intranasal corticosteroids along with the even IV corticosteroids also in such patients, sir, because if they are in the very critical stages. But I try to withdraw the antihistaminics because fexofenadine particularly, if cardiologists say the cardiac complications are there. This is my point of view, sir.
And Agam sir, what would you like to say about that point, about the corona situation and this add-on effect of fexofenadine?
Interesting. I was just going through Dr. Zarir Udwadia's article a couple of minutes ago, and he's just published it in JAPI along with Dr. Shashank Joshi, and they've really questioned the treatment, the way we are probably treating our patients. There is a lot of controversy, a Lancet article and the ICMR recommendation which just came today, and then we really do not know how to manage corona patients. But not going into that discussion, a lot of doctors, a lot of healthcare providers are on HCQ, what you rightly said. Most of these patients at most of these centers are receiving one of the macrolides, commonest being azithromycin. And it is a well-known fact that azithromycin and HCQ both would prolong QTC interval. To give you a very honest answer, in my practice, I have not come across any situation where I had to stop any antihistaminic for the want of QTC prolongation. And to again be very honest with you, I have not really done many ECGs to look at QTC prolongation before any initiation of antihistaminic in my OPD practice. So you imagine a scenario, most of us see asthma and allergic rhinitis in a younger population. You don't see asthma, you don't diagnose first time asthma in patient who are 50 or 60 years old with many comorbidities in most of the situations. So your majority of chunk of asthma and allergic rhinitis will be relatively younger population where they may not have many comorbidities. You may have sporadic situations where you find late onset asthma or you diagnose asthma in elderly which was not picked up earlier. And in those situations, if you have to use some drugs, you may do baseline ECG and then consider, but there you will do ECG in any case. Suppose if I get a 65 years old patient for the first time and I'm suspecting asthma or I want to differentiate asthma from COPD, I'm going to ask for a baseline ECG for sure. And there, of course, QTC will be checked. Now, when it comes to corona treatment, let's be very honest and ask ourselves, in corona patient, if somebody is admitted with shortness of breath and corona, who would want to treat allergic rhinitis at that stage? We are putting our treatment focus on more serious issue than this. Second, a lot of these patients are already on injectable steroids or oral steroids for that matter when they have respiratory symptoms. And there you don't really need, because one of the strongest anti-inflammatory anybody could think of is steroid. And if you're giving systemic steroid, there is no question of putting them on antihistaminic drug. So I would look at situation of using antihistaminic only when I see drug reaction happening with any of the medicine that I've used, or patient of corona who's presented with skin involvement. In those situations, I may have to use antihistaminic. Okay. In that situation, anyway, you're doing daily twice ECG because your patients are on HCQ and your patients are on macrolide. So you will have idea about QTC and QTC prolongation happening there. Again, given choice, I would like to treat this patient with belastin for sure, because you have a newer molecule and you know that this molecule does not lead to QT prolongation. I would definitely recommend using belastin if you have to use in COVID scenario where patients are on associated therapy. Advantage of belastin is not only safety, but also dose flexibility. 20 milligrams once a day would be enough to control your allergy symptoms for more than 24 hours. But you can at least double or at least triple the dose if anti-allergic requirement is high. That means you can give them 2 or 3 times the recommended dose. 20 milligrams can be escalated up to 60 milligrams if need be. Only care we have to take it is we have to give it on empty stomach. Because if you give it after food, the availability goes down by 30% and probably it may not really be as effective. So these are the few things one would keep it in mind.
So sir, actually our time we have exceeded quite a lot. So I think it's better if because we're still getting questions, but this will go all night if it goes like this. So if you both don't mind, shall I conclude our seminar
Before you
for today?
conclude, I have to,
Yes, yes.
before you thank everybody, I have to thank everybody. I have to thank you for moderating it so well. I mean, I think whenever we are doing any program, we need a strong moderator like you. I am really grateful to Dr. Giriraj Bomna for the excellent clarity of thoughts that you have, and the way you have presented, the message is really something that I learned something from you today. I'm so thankful to, Amitash for being there. I'm so thankful, Dr. Mishra, who's my friend. You mentioned about Dr. Krishna Kumar. Krishna Kumar is a physician who's practicing in Mira Road. Here is my friend who's asked me those questions. So many doctors have continued to be online, have bombarded you with this question. But I must mention special thanks to NH Krishna. Krishna did wonderful job. A small thought has been such a big wave. Probably 4 years ago when he had this small idea of creating a small group, and that from one group, God knows how many groups are there, and every time I see more and more members becoming, more and more chess physician wanting to be member of the association. I don't know how he manages. Today, I saw him in the sepsis webinar also. I saw him in the previous webinar also. There was some technical issue and he could not log in, or probably he must be on the kitchen duty because everybody is going through the same time. I don't know. I will have to check with him that either he's playing with his daughter or he's doing kitchen duty and cooking food. But whatever, I think he's doing better job than probably what we did. Is I did not want to sweep floor today, so I thought I would probably do the program and I could skip myself from the household duties. I must also thank the House of Cipla for giving me this platform, the web stream, the platform provider and the help. I think Sahil and Rohin and I see a few names there. They have really helped us. So I'm really grateful to all of you for this opportunity. Over to you, Dr. Tony.
Yeah. So I would really like to thank our Dr. Agambora and Dr. Giriraj for giving their time for us today and helping clear so many doubts that our participants had. And especially I would like to thank all our participants, all the doctors and public who have logged in and had the patience to go through our webinar and have the courtesy to ask a few questions. And we try to answer as much as possible at this point of time. And definitely down the line, we will have more webinars and more opportunities to ask questions. So for today's, I'll be closing this. And I would like to thank especially our CCI core team of Dr. NH Krishna sir, our president, and Dr. Narayana Pradeepa, who's our general secretary, for organizing this. And I would like to thank Cipla Respiratory for taking the trouble of doing this for us. So thank you, everybody, and have a safe night. Good night.
Thank you. Good night.
Thank you. Thank you very much.